Hello, Eugenia.
Hello,
Hello.
Hello, hello.
Adi. Hello, good morning, everybody. Mon chéri, Erki. Hello, Joey.
Salut.
Good morning. Good to see
Oliver
you.
Wolfram. Ana Gloria, querida, buenos días. Soledad,
Hola.
buenos días. Hello, Liza, great to see you. Jonathan.
Hi everyone.
Hello.
It's late afternoon here.
I know. And here's
Nearly evening.
first. And Andrea Ricci Maccarini, carissimo Andrea, ¿cómo
Ciao,
estás?
ciao, 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 ciao.
Dear Adi, hello, how are you, dear Adi from Tel Aviv? My Ilter, great to see you again very soon from Turkey, Izmir. And well, this is a great pleasure to see you again. And we are going to have a wonderful, wonderful presentation day and also many surprises. And hi, my dear Ron, great to see you. I saw you 2 weeks ago, I think. Great to see you, Ron. Great that you are here. And really, I am very thankful that you are here with us. And I think we shall begin officially. And I really appreciate all your efforts and your time, because as we know now, the world is moving all around, but we are still in CoMeT enjoying this artistic voice presentation. So let's begin with the first presentation, Jonathan Fishman, and I will read a little bit of his curriculum. And so may I have the first video? So Dr. Jonathan Fishman is from United Kingdom. He's a consultant laryngologist from University College London Hospitals and from Royal National ENT Hospital. At the moment, he's also honorary associate professor in UCL, senior editor of Journal of Laryngology and Otology and at the University College London. I'm sorry if I make some mistakes. He studied in the University College of London from 2011 to 2014, and he has his PhD degree from this university. Also, he studied the clinical medicine at the University of Oxford, St. John's College from 2001 to 2004, and the preclinical medical sciences at the University of Cambridge in Sydney Sussex College. And he is at the present, since 2016, senior editor for the Journal of Laryngology and Otology. Is a current leading UK ENT journal, established wonderful in 1887, so a great history. And Jonathan is since 2018 elected council member of the British Voice Association, and since 2015 until now elected council member of the British Laryngological Association, and since 2018 and until now, he belongs to the scientific committee for the European Laryngological Society. And also, he is a committee member from the airway lead for the National Hospital for Neurology, Neurosurgery, UCLH, and Airways Steering Committee. And well, I had to summarize a lot of his curriculum. He has the recent advances in technology. He has a chapter in this book about optical coherence tomography. He also has written many articles and a chapter in stem cells in regenerative medicine, and also the acquired immune system response to biomaterials, including both naturally occurring and synthetic biomaterials. He also has a lot of experience and has written a lot of articles and also chapters about surgical and translational aspects of tissue engineering. And of course, about emerging approaches to laryngeal replacement and reconstruction, and as well as tissue engineering for non-cardiac and intrathoracic organs in the state of art he presented in 2010. And of course, the next one, please. And here we are going now to enjoy all this wonderful presentation about what Jonathan is going to tell us. Please enjoy.
Dear friends, it is a great honour to be speaking to you today about the advances in the studies of voice. What have we learned in the last 10 years? My name's Jonathan Fishman. I'm an ENT consultant and consultant laryngologist and voice specialist at the Royal National ENT Hospital, University College London Hospital in London, United Kingdom. I also do sessions at the National Hospital of Neurology and Neurosurgery, where I have an interest in neurolaryngology. I'm an associate professor at University College London, and I'm an editor of the Journal of Laryngology and Otology, which was established in 1887 and is the UK's oldest ENT journal. I'm proud to be a CoMeT member and fellow as of last year. So what I've done in this presentation is I'll be discussing what I consider to be the top 10 most important things that we've learned in the last 10 years in the field of voice and laryngology. First of all, HPV vaccination. Laryngeal papillomatosis is a devastating disease which can affect the voice and airway. The Gardasil vaccination has been in widespread use in the UK, and girls have received the vaccine for several years. From September 2019, this has also been offered to boys as well. We are becoming increasingly knowledgeable about the vaccine, and several systematic reviews to date have studied the use of the Gardasil vaccination in active laryngeal papillomatosis, and it's shown a significant reduction in surgical procedures with an increase in intersurgical interval. In other words, the time in between surgeries. We now offer all our patients at our hospital Gardasil vaccination for patients with active and histology-proven laryngeal papillomatosis, which is a cost-effective and clinically effective way of managing the condition, reducing the need for patients to come in for regular surgeries. The second area of advances I'll be discussing is use of pharmaceuticals. I've divided this into several drugs which are being increasingly used in laryngology. First of all, Avastin for papillomatosis. This works by inhibiting the VEGF, which is the vascular endothelial derived growth factor for patients with papillomatosis, although more research is required to understand the optimal treatment or dosing protocol and whether systemic or intralesional Avastin is more effective. Although preliminary studies suggest that systemic Avastin is more effective than intralesional. The work of Christina Simonian has studied the role of sodium oxybate in laryngeal dystonia, and this is another area which we hope to look at our hospital to study the effectiveness of this drug in patients with laryngeal dystonia. There has been some work looking at the use of growth factors, for example, basic fibroblast growth factor and hepatocyte growth factor for vocal fold regeneration, which we'll be discussing later. This could be particularly useful for patients to have vocal fold scarring or sulcus vocalis, as our current treatments are suboptimal, or in those patients with presbylaryngis, where vocal fold augmentation is less successful. However, caution is required, as these growth factors, we must remember, are bioactive substances and have the potential to cause carcinogenesis. The third area I'll be discussing is aerosol science. So 3 years ago, we went into a global pandemic, and the role of office laryngoscopy has been much debated as to whether this was an aerosol generating procedure or not. Early on in the pandemic, there was fear that laryngoscopy was aerosol generation, but more recently it's become increasingly clear that this is minimally aerosol generating. Perhaps the most widely cited study at this point in time is this study by Bastian et al. That was published in JAMA Otolaryngology Head and Neck Surgery last December, who quantitatively evaluated aerosol generation during in-office flexible laryngoscopy and found in 134 patients no statistically significant aerosol, as defined by particles less than 5 micrometers, above baseline in either visits involving flexible laryngoscopy or visits where flexible laryngoscopy was not performed, and that the use of nasal, topical anesthetic spray did not result in increased aerosol. We have therefore come to the conclusion more recently that laryngoscopy is therefore no more aerosol generating than baseline conditions of breathing or phonation, which contradicts some of the earlier studies that we saw within the pandemic. Continuing this theme, we're beginning to understand more as the years have passed how COVID and the larynx interplay with one another. So over the last few years, we've seen a significant increase in the number of complications of COVID that affect the larynx, and that can be divided into the acute stage early on in the pandemic, where we saw inflammatory type problems within the larynx, to ongoing long COVID problems with the voice in particular, such as phonoasthenia. But what I've done here is I've listed the laryngeal complications of COVID that we have seen, such as granulomas, airway stenosis, impaired mobility, non-specific vocal cord issues, respiratory sequelae with reduced lung function, and long COVID. And we've set up a long COVID dysphonia study, which is a pan-European study to assess the effect of long COVID on vocal outcomes. The fifth area where we've seen advances in the last 10 to 20 years is the field of laryngeal allotransplantation. The first laryngeal transplant was performed in 1998, and subsequently there have been 2 further transplantations that have taken place in UC Davis in California, and then more recently a third one within Poland. This has the ability to transform patients' lives that would otherwise be tracheostomy dependent without a voice. One of the challenges has been how to restore mobility of the vocal folds following allotransplantation, and there are several techniques that could be considered to allow this, including selective reinnervation following the work of John Paul Marie, addition of neurotrophic factors to try and encourage nerve ingrowth to prevent the effects of synkinesis, electrical stimulation, for example, use of laryngeal pacemakers, and optogenetics, where, for example, genetic engineering techniques can be used to stimulate the muscle. An example of the latter can be seen on the right of a technique where the rhodopsin, which is a light channel, has been genetically engineered into the posterior cricoarytenoid muscle of the larynx, which allows the muscle to contract in response to light stimulation. And in the bottom video, you can see that when the light is placed on the larynx, this allows the PCA muscle to contract, thereby opening the larynx. The next area is the field of electrical stimulation. Several studies in the last 10 years have looked at the use of laryngeal pacing, where a small pacemaker is inserted into chest wall, and then the leads are fed into the posterior cricoarytenoid muscle to stimulate opening of the larynx. This would be particularly clinically useful in the case of patients that have bilateral vocal fold paralysis who have airway concerns. The next area is the field of the artificial larynx and soft robotics. In 2017, an artificial larynx was described by Debris et al. In the New England Journal of Medicine, which is a prosthetic larynx to replace the native larynx. The next area is the field of stem cells and regenerative medicine. I believe that this is a particularly important area and offers great advances for the future of artistic voice. Regenerative medicine in particular is the use of cells and tissues to restore or replace function. This can be divided into cells, stem cells, gene therapy, biomaterials, and nanotechnology. Stem cells in particular offer great promise. These can be divided into embryonic stem cells or adult stem cells, such as mesenchymal stem cells, and more recently induced pluripotent stem cells. But what is a stem cell? A stem cell really is a cell that has the ability to divide and differentiate into any cell of the body. So for example, it could be used to replace missing cells of the vocal fold to try to restore the lamina propria, which is so important in generating the mucosal wave for voice. Tissue engineering is a technique which combines the use of stem cells with biomaterials, also known as a scaffold, to recreate or regenerate tissues. When we're thinking about vocal fold regeneration, cells can be divided into endogenous cell sources or exogenous cell sources. The endogenous cell sources are trying to make use of the cell populations within the native larynx to try to regenerate tissue, as opposed to exogenous cell sources where the cells come from outside the larynx and are put back into the larynx to try to regenerate the missing tissues. This is particularly important in patients that have sustained damage to their larynx, for example, scarring or trauma or previous cancers, to name a few examples. This is a study in 2015 where the investigators were actually able to tissue engineer vocal fold mucosa for voice restoration. On the left, you can see the engineered tissue, and on the right, you can see the native tissue, and you can see that the mucosal wave is performing quite well. On the right, you can see the acoustic analysis. This is the acoustic analysis of the native tissue. The vocal fold tissue has been resected on the left. And then here the engineered tissue is put back in. I'll just play that again so you can see. This is the native tissue, the resected tissue with no fundamental frequency, and then the tissue engineered construct that's been put in on the left side. This is an ex vivo animal model, so it's all been done in the laboratory, and ex vivo meaning it's outside the human body. But it does offer the prospect of being able to tissue engineer vocal fold tissue in the future. More recently, the use of mesenchymal stem cells have been looked at, and Hurtigard at the Karolinska in Sweden has actually performed a phase 1 to 2 clinical trial in 16 patients with surgical scar resection, followed by the injection of autologous mesenchymal stem cells. Patients were followed up for 1 year and no serious adverse events or minor side effects were reported. Video ratings of vocal fold vibrations and digitized analysis of high-speed laryngoscopy significantly improved for 62 to 75% of patients. 2 patients showed deterioration in vocal fold vibrations. The VHI was significantly improved in 8 patients. Vocal fold vibration and elasticity were improved in approximately 2/3 of patients. And the results indicate that local injection of autologous mesenchymal stem cells into scarred vocal folds with severe dysphonia may offer a safe and feasible therapeutic option. However, it should be stressed that this is a small study with a limited number of patients and a lack of a control group, and we look forward to seeing randomized controlled trials in the future. The 9th area I'll be discussing is the use of biomaterials and nanotechnology. In terms of vocal fold augmentation for patients with vocal fold immobility, we still don't have an ideal injectable material. Although we use materials such as hyaluronic acid and calcium hydroxyl apatite, these are still suboptimal. What we require is a material with a long-term safety profile that's resistant to migration or resorption so that it's long-term. A material that has a similar viscoelastic property to the native vocal fold, requires minimal preparation, is easy to inject and cost-effective. And as mentioned, no such material exists. But through the field of biomaterials and tissue engineering, we're looking to study and understand new materials that hopefully will be able to help us in the future for patients with vocal fold immobility, or where biomaterials are required to replace the superficial lamina propria or Wenke space to regenerate the mucosal wave. This is a recent study looking at the use of jellyfish collagen, which has a similar molecular structure to mammalian collagen, and this is an area that looks promising for new materials. This is just one example. The final area I'll be discussing is advances in technology, for example, the use of surgical robots, imaging, artificial intelligence, and so on. So transoral robotic surgery is becoming increasingly used within areas of medicine and head and neck surgery. And the question is whether we can apply similar robots for phonomicrosurgery for patients with small lesions affecting the larynx. The robots are becoming increasingly smaller and offer 360 degrees of freedom, which allows the surgeon to manipulate the arms in different directions. Other techniques have also been described, for example, optical coherence tomography, or OCT. And this is basically a way of interrogating the larynx non-invasively. And we can expect to see other imaging techniques that will allow us to study the larynx in more detail without having to subject patients to biopsies, for example. We can also expect a massive rise in the use of artificial intelligence to non-invasively assess the larynx in more detail. So to conclude, we have seen a massive rise in technological advances in the last 10 years within the field of laryngology, and we've learned a huge amount in the process. And I would argue we can expect similar or more in the next 10 years. I'd be happy to discuss any questions that you may have on my presentation. I'd like to thank you for your time today. And as mentioned, I feel extremely privileged to be joining this group of elite laryngologists from across the world. Many thanks.
Thank you very much, dear Jonathan. So as you see, dear friends, this is a great acknowledgement to have all this great research together. And now we are enjoying the presentation of Professor Dr. Ron Scherer from the United States of America. He's a distinguished research professor from the Department of Communication Sciences and Disorders at the Bowling Green State University. He has his PhD in speech science in 1981 at the University of Iowa, and a master's degree in speech pathology and audiology in Indiana University in 1972. He has also a Bachelor of Science in Mathematics in 1968 at Kent State University. He has made a lot of research. He is a great presenter. He has been doing many courses all over these years. For example, courses in speech science, in voice disorders, acoustic phonetics, physiological phonetics, laryngeal modeling. And I tried to resume also from 1996 till 2014. He was an affiliated scholar at the Oberlin College in the Conservatory of Music. And also 2014, he had an awarded title as Distinguished Research Professor in Bowling Green State University. That was on May 9th by Board of Trustees. 2011 to 2016, he's a principal investigator of the National Institutes of Health with many research. At this time, aerodynamic and acoustic models of phonation, and then voice source and airway interaction in normal and hyperfunctional speech. And now from 2023 to 2024, he's a consultant in the Shanxi Provincial Department of Science and Technology of China, with this very interesting research, asymmetric vocal fold phonation mechanism based on phonation aerodynamics, modeling, and deep learning. Great. And I have the other one. So from 2023 until 2028, he is consultant also at the National Institute of Health from the United States with this mechanistic examination of psychophysiologic stress profiles in adults with and without functional voice disorders. Very interesting. And also from 2023 until now, he's a research consultant as member in the Scientific Advisory Committee in the Clinical Research Center for the Improved Prevention, Diagnosis, and Treatment of Vocal Hyperfunction with Robert Hillman. As you know, Robert Hillman is in the Massachusetts General Hospital in Boston. And our dear Ron has multiple honors, recognitions, awards. So it's great to look at his wonderful curricula. And may I have the next one? He belongs to many of the most important societies: Acoustical Society of America, American Speech Language and Hearing Association, CoMeT since 1995. Thank you, Ron. European Acoustic Association, National Association of Teachers of Singing, National Spasmodic Dysphonia Association, Ohio Speech and Hearing Association, the Voice Foundation, Voice and Speech Trainers Association, Pan American Vocology Association, and Performing Arts Medicine Association. His general areas of research interest are acoustics and aerodynamics of speech, laryngeal science with fluid mechanics, biomechanics, non-invasive techniques, fatigue, and of course, professional voice production. I thank you very much, Ron, for this wonderful presentation we are going to enjoy now.
Thank you very much for the opportunity to talk about the air pressures in phonation that allow the vocal folds to vibrate. The title of the talk is Overview of Interglottal Surface Pressures During Phonation. This work was supported by an early NIH grant. Transglottal pressures drive the vocal folds into motion by pushing up on them, and also drives the air through the glottis when the vocal folds are separated. Interglottal surface pressures are those that are pushing on the medial surfaces of the vocal folds themselves. And when the vocal folds are going out, they are positive pressures, and when they're coming in, they are negative pressures. These pressures control proper phonatory function in speaking and singing. Let's look at vibration of the vocal folds for a minute. This is from Hirano's famous video. Typically, the vocal folds move as mirror images of each other at different amplitudes. Sometimes they are not mirror images, they are asymmetric in motion. We'll talk about that later, perhaps. And then when the vocal folds are seen in the frontal view, they touch, then they go apart, and they come back. And when they are going apart, the glottis is showing a convergent glottis, and when they're coming together, they show a divergent glottis. Before going into that further, let's look at airflow through the glottis. If we take a look at this larynx here, where we have arytenoid cartilages, posterior glottis, the right and left vocal fold, and the glottis proper if there was some space there. And this is a canine from Sid Kosela's lab, where we have again the arytenoid cartilages, the posterior glottis, right and left vocal folds, and the glottis opening here. So let's look now at airflow through this canine larynx. The air is seated, and it's going to be backlit, so to speak, so that you can see the vibration of the vocal folds as well as the airflow coming through the glottis. These are the air puffs that occur each cycle. The flow is turbulent after it exits the glottis, and we look at the volume flow, cubic centimeters per second, of that flow during each cycle. So when the vocal folds are touching, there's no flow, or the only flow is posterior glottis. And then when the vocal folds begin to separate, the airflow begins to come through the glottis, and the shape of the glottis is convergent. And that convergent glottis has positive air pressure that pushes the vocal folds to separate them during the beginning of the cycle, and that pressure is positive because the tracheal pressure is positive. And then the vocal folds reach a maximum separation from a vertical perspective, but that's not when the glottal flow is maximum. The glottal flow is maximum when the folds turn to come back toward each other. That shows a divergent glottis, and what happens, that is, this peak flow here is later than the peak glottal area, and that's called skewing to the right of the airflow. And it's due to inertance of the air, because when the air comes through the glottis, it's got to push air. It's also due to the divergent shape of the glottis, and also due to wall movement as the walls come toward each other. The pressure in the glottis during the return is negative when the glottis is in a divergent shape, and that negative pressure is due to Bernoulli. That negative pressure pulls two vocal folds toward each other to help close the glottis. And that negative pressure is due to the Bernoulli effect. That's the only time it occurs. Rarefaction, as well as rarefaction above the glottis, because as the flow comes through, the earlier flow is going faster than the later flow, and so the air particles separate, making a negative pressure, and that communicates into the glottis. And there are also vortical structures that Dr. Sid Kosela has been had been investigating. And then notice that when the vocal folds are maximally apart, the primary force to pull the vocal folds toward each other is actually a recoil of the tissue. Then the vocal folds continue to come together, and the airflow is being shut off. It's like turning the handle of a faucet at your sink. And then they finally touch, and then there's the closed phase, when the only flow is basically through the posterior glottis. So there are three phases of the motion of the vocal folds corresponding actually to the airflow, except for when the peak occurs. The first phase is glottal opening, the second phase is glottal closing, and the third is glottal closed. During glottal opening, the vocal folds are separating. During glottal closing, the vocal folds are coming toward each other, and during glottal close, the two vocal folds are touching. So what are the air pressures on the vocal folds for phonation? And we've studied this using the model M5. Model M5 is a plexiglass model where we pull airflow through a tunnel where there are two vocal folds inserted. This is what the gadget looks like. Here are two vocal folds here. The air comes this way. So we have the two vocal folds left and right here. Over here there's a pressure scanner and a pressure transducer, and we measure pressures along one of these vocal folds, and the vocal fold looks something like this. There are 14 pressure taps from the inferior vocal fold surface along the medial surface and then above. This is what a vocal fold insert looks like. Here are these little pressure taps that we measure pressures with. And on the back end of that, these little tubes go to the pressure scanner tubes. If you take the convergent shape here when the vocal folds are separating and turn it 90 degrees so it looks like this, then we can talk about these pressure distributions. So this figure here is a convergent glottis. Here's the entrance to the glottis and the exit to the glottis on the right. And the flow is coming this way, so this is inferior, superior. And these arrows show that the pressures are positive, trying to push the vocal fold away from each other. And up here is a rendering of that. This says 10 centimeters of water, and this is 0 here, this red line. So it's 10 centimeters of water here in the trachea. And as the convergence occurs, the pressure decreases. But for convergent glottis, the pressures in the glottis on the surface are positive because this blue line here is above the red line. If you have a divergent glottis, this is the entry, and now it's divergent because it's becoming wider as you go from upstream to downstream in the glottis. The pressures are negative, and that's shown up here. Again, the red line is 0, so this blue line here is below 0, and so these are negative pressures. In general, if you have a convergent glottis, the pressure is positive in the glottis, which is the glottis is this region between this red line and that red line. So convergence pushes on the vocal folds, the pressures are positive. For divergence, the pressures are negative. And if you take different angles, convergent angles like 5 degrees convergent to 40, all these are positive pressures when the glottis is convergent, and all these are negative pressures when the glottis is divergent. And by the way, all of these are empirical values from model M5 for a diameter of 0.04 centimeters, and it shows here an upstream or transglottal pressure of 10 centimeters of water. So that's a general orientation relative to intraglottal pressures. Now, if you take that same sequence of 10, here is a convergent glottis, and it's estimated here it's about 11 degrees convergent and about 0.09 centimeters diameter minimal. The closest thing we have here for our data with M5, which covers 63 different configurations. This is the pressure distribution, and this is the pressure distribution on the two sides of the right and left wall, the right and left medial surface of the vocal folds. This is for 3 centimeters, 5, 10, and 15 centimeters of water. So as you can see, in the glottis, primarily the pressures are about the same because it's convergent. But if you take a divergent case like this case here, this is what the pressures look like. Actually, you get a difference on the two sides. The side on the left side here, for example, might have a different pressure distribution than the right side, if you can see the cursor up there. And that's due to the flow actually going toward one side when the glottis is divergent. And this yellow line here is a real flow simulation, and this pressure would be more negative than on this other side. And more negative would be like this lower line here. And these patterns are consistent up to pressures that singers use, for example, above, say, 25 centimeters of water. And these kinds of distributions are similar. So you can actually get, in a symmetric case, you can get asymmetric pressures in the glottis. It depends a lot on the curvature of the glottis, actually, and what's right above the glottis. Now, let's look at a 3-mass model. This is one vocal fold here. This is the medial surface. So this is the inferior surface. And let's model that with a mass down here, M1. And then the glottis proper is from tap 6 here, right here, through here, actually. This is the glottis. So we have a lower mass for the glottal region and an upper mass, which is less massive. We apply all the measures from M5 into that model, and we get motions like the following that I'm going to now show you. So As the vocal folds are vibrating, which they do vibrate with the wide range of pressures that we obtain at M5, you get this kind of movement of the masses, and down here the blue, red, and black are trajectories of the motion of those masses. And in this kind of modeling here, not only do we get this airflow, the airflow you see here, this is the glottal airflow through here, and that's the source of sound. That changing airflow is the source of sound and phonation. Not only can we get that airflow, but also the motion of the folds and the angle of the glottis and the output like a microphone signal. What if there's this asymmetry in the glottis? So let's look at quickly two cases. The first case here will be one where the glottis is convergent, because these two red lines create a convergent glottis, but the glottis axis is oblique. And what happens when that's the case? One side here is convergent and the other side is divergent. So what happens there? Well, let's look at the distributions relative to how separated those two vocal folds are. So if they're pretty close, this is when the diameter is only 0.005 at the top here, 0.005 centimeters, the pressures on the two are quite similar. That is, the glottis doesn't know that it's oblique, and so it's going to push basically equally the two sides. But as you increase, see this 0.4, 0.8, increase the diameter between them, then on the convergent side you have a positive pressure that pushes the fold out like it should for convergent, but on the divergent side you have pressures that pull like a divergent side should. So when the obliquity is there, but it's convergent glottis, when the glottis is narrow, it works correctly relative to a convergent glottis, pushing basically equally on the two sides. But if you now have that same configuration but at a larger diameter, aerodynamically they are almost separate, because now the pressures on the convergent side push and the pressures on the divergent side pull. The consequence of that is it probably helps to maintain the asymmetry of motion. So in summary, interglottal pressures push and pull the glottal walls to help produce phonation. The source of sound in phonation is the changing glottal flow created by the coordination of movement of the vocal folds and the changing transglottal pressure. By the way, the source of sound is not the vibrating vocal folds. It is the glottal flow that comes through the glottis. An asymmetric motion of the vocal folds produce asymmetric driving interglottal surface pressures. The latter may perpetuate the asymmetric motion, never the end. Thank you very much.
Thank you very much, Ron, for this great presentation. And well, we can see so different aspects from basic science research that is so detailed, examined, and with such a great structure as basis to understand many of the pathological and of course of the physiological way of acting of our vocal folds. So it is really great. And I may say hello to Iris Rodriguez from Argentina, to Isabel Garcia Lopez from Spain, Alfonso Borragan, also from Spain, Santander, and also I invited Ramon Hernandez Viloria from Venezuela and Ananji Quiroz from Costa Rica. So welcome. And I may present now the curriculum from Jeremy Hanhui. He is a clinical assistant professor in the Department of Communication Sciences and Disorders at Baylor University. He teaches undergraduate classes at the Communication Sciences Disorders Department, coordinates activities within the voice clinic, and supervises speech-language pathology graduate students as they evaluate and treat clients or patients in the voice, neurorehabilitation, and general clinics in the Baylor Speech, Language, and Hearing Clinic on campus. He has a Bachelor of Music with summa cum laude in choral music education at Sam Houston State University in Huntsville, Texas in 2002. May I have the next one, please? And also, Jeremy, may I have the next one? Well, I'm just reading small parts of the curriculum. So he has a Master of Science at Baylor University in Waco, Texas in May 2005. And the communication science disorders, he also got summa cum laude. He's a licensed speech language pathologist. He worked for 11 years in Texas Voice Center with our dear CoMeT friend, Dr. Richard Stisney, and his group in Methodist Hospital in Houston. May I have the next one, please? The areas of practice, teaching, and expertise of Jeremy is the evaluation and treatment of voice and upper airway disorders, prevention of voice disorders, vocal health in occupational voice users, and at the moment he also has this teaching in anatomy and physiology in the same communication science disorders department, technology and science, and clinical practicum in speech pathology. And we enjoy Jeremy's presentation.
My name is Jeremy Hathaway, and I am a speech-language pathologist and clinical assistant professor at Baylor University in Waco, Texas. Prior to becoming a speech-language pathologist, I studied music education with an emphasis in choral music and vocal music, and student taught at both the elementary and high school levels prior to beginning my degree in speech-language pathology. I went into speech-language pathology because I had a problem with my singing voice in high school, and working with a singing voice specialist discovered that this field existed and was something that I was interested in, being able to combine that music and science aspect and rehabilitation aspect of this field. So upon completion of my master's in speech-language pathology, I then worked for the Texas Voice Center in Houston, Texas for approximately 11 years, working alongside Dr. Dick Stasny and Dr. Apurva Thekti, evaluating and treating patients with voice disorders. Then in 2018, the Lord called me to Baylor University, where I have been since, and my goal has been to grow our voice clinic. I also have the opportunity to teach a couple of undergraduate courses, including anatomy and physiology for our CSD majors. And then I get to supervise graduate students as they work with clients in the voice clinic, as well as in our neuro rehab clinic and our general clinic. Today I want to talk with you about a partnership that we have created at Baylor between the CSD Speech Language Pathology Department, the Vocal Music Department in the School of Music, and the Theater Department in order to both care for our student performers as well as collaborate between these three departments. So Baylor's mascot is the bear, and so we have named our collaboration Vocaloso. This collaboration really Talks for This started years ago, but didn't come to fruition until about 2016, when interested parties from the speech pathology department and the School of Music, the vocal department, came together to talk about how we could benefit each other as well as the students in both departments. So I'm thankful that we have applied voice faculty here at Baylor who are very knowledgeable within vocal health and were interested in this collaboration. The CSD department, because we are not associated with a medical school, we found that getting experience, voice experience, for our master's students in who are studying speech pathology was difficult. And so we were looking for a way, or the CSD department was looking for a way to get additional experience in helping both with voice disorder prevention as well as voice disorder treatment for our graduate students. And then the applied voice faculty, we're looking for ways to help both with research as well as then getting help for their students when those needs arose. And so this collaboration then started with those two departments. Then because we are not associated with a medical school, we ended up talking with one of the fellowship-trained laryngologists, Dr. Brad Holland, here in the Waco area, and he was interested in joining this collaboration. And so we were able to bring him on as an adjunct faculty here at Baylor to be able to help with this. The speech pathology department faculty members then sought out training for endoscopy and purchased the equipment for performing laryngoscopy here in the clinic, and then started working on scheduling opportunities for students in the School of Music to come over for some vocal screenings. And we'll talk more about what those vocal screenings look like and how we're serving those students here in a few minutes. But then about a year later, the music theater department, or the theater department in general, but even more specifically the music theater department, joined this collaboration. One of the faculty members there was very interested in vocal health and a great advocate for her students, for taking care of their voices, and was interested in joining this collaboration. Our Vocaloso partnership between the Speech Pathology Department, the School of Music, and the Music Theater Department has multiple goals, one of which is to help ensure that the students in the music and music theater departments are taken care of as far as their voice is concerned, as well as to help prevent the development of vocal issues within those populations. And so one of the things that we've been able to do is for the speech pathologists to go into those schools and talk with the students about vocal health. Each fall semester, I have the opportunity to go in and talk with the freshman students in the theater department about vocal health, vocal hygiene, and give them some information about voice disorders, prevalence of voice disorders, symptoms of voice disorders, and talk with them about what to do if they're experiencing symptoms of voice issues so that those things don't develop and worsen. Within the music department, that is a little less frequent. I've had several opportunities to go over and talk with them, but it has not yet been an annual thing. I'm hoping that here in the near future we will be able to have an annual vocal health seminar for the vocal music students. And eventually I'm hoping to be able to involve our graduate students in that vocal health, vocal hygiene presentation to give them the opportunity to present this information to their peers within our school. Several of our voice teachers also give vocal background forms to their students to complete at the beginning of their time here at Baylor. Some of that is general information about their vocal experience and any vocal symptoms that they may have had, as well as giving them some of the patient questionnaires that are filled out by patients within a voice clinic. And through that, then they work to talk through those things with the students to help identify students that may be at risk or may already be experiencing voice issues early in their time at Baylor, then to be able to get them help as soon as possible here at the Voice Clinic. Another layer of our initial vocal health and caring for these future performers is our Vocaloso screenings, which are a collaborative effort between Dr. Holland, our ENT in town, and our CSD department. So we have worked to schedule about 5 or 6 vocal screenings each semester for our for the vocal music and theater students, with the goal of having each of those students given the opportunity for a vocal screening 3 times during their course of time at Baylor. Once their freshman year, again the end of their sophomore, beginning of their junior year, and then again just before they graduate. The goal of these screenings are multifold. One is to identify students early who have a voice disorder or have or experiencing voice issues and get them in for treatment. Another is to give the students a baseline exam so that if they were to ever have a voice issue after they get out into their respective fields, they would then, and had a voice problem, they would have something to compare to. The other then is to be able to see growth or changes over the course of time of their training. So with these vocal screenings, we do a laryngeal examination, and then we also take acoustic and aerodynamic measures. Not a full voice evaluation, but some acoustic measures and aerodynamic measures to see what those changes potentially are as the student continues in their training. Beyond these screenings, the voice teachers are also listening for and looking for potential issues with vocal issues that the students in their studios may have. And when they identify a student as having a potential problem, then they contact me, and I then work with the ENT to determine whether that student needs to be seen immediately and needs to be referred to the ENT office, or if we can work them into our Vocaloso screening schedule, or if we need to try to get the student in for a vocal exam here outside of that schedule. When a student is identified as having a voice disorder, the ENT then writes that order for us to begin voice therapy, and we get them into our voice clinic to start working with our graduate students as soon as possible. Within these vocal screenings, the graduate students are the ones that are taking the acoustic measures and the perceptual voice evaluations, giving them experience with those voice clients, as well as some of them have the opportunity to observe the endoscopy and talk through the findings. When a student is enrolled in therapy, then we also, because of the collaboration that we have, are able to communicate with the student's permission with their voice teacher to find out what the voice teacher is experiencing within the lessons, and the things that may be working well within the voice lessons that we can bring over into the voice clinic to help the student, or vice versa, things that are working well within the voice clinic that might be able to be used within the student's voice lessons to help the student progress. And then the voice student is communicating both with us in the clinic as well as the voice teacher. The student, as they are receiving voice therapy here in the clinic, are being treated by our master's level graduate students, and typically I am the supervisor that is supervising all of the voice treatment. Also, thanks to the generosity of our university, the voice therapy evaluation and treatment, as well as the vocal screening, the laryngeal examination, the acoustic and aerodynamic measures, are all able to be offered to our students enrolled in the university for no cost. In addition to these vocal screenings, we've been able to engage the community through World Voice Day celebration. We had one in 2019, which was a collaboration between the music department, the music theater department, the CSD department. We did vocal screenings. We did another World Voice Day celebration in 2022, where we had performances by the music department and some of our voice and music theater faculty. And this has also led to a few interdisciplinary presentations at the Texas Music Educators Convention this year, as well as the Texoma National Association of Teachers of Singing Conference. And then will hopefully also lead to some research. We are looking at some retrospective research on some of the information that we've already gathered, as well as hope to have some prospective studies from this Vocaloso collaboration in the works soon. Thank you very much. If you have any questions, I'm happy to answer those.
Thank you very much, Jeremy. I'm sorry I made a mistake. It is not PhD, it is a master's degree. And I thank you, and this is interesting to see all the movements in education and in prevention, and of course in supervising all the singing students and acting students. Thank you, Jeremy. And I may present Ana Gloria Ortega from Argentina. She's a speech pathologist, a PhD, vocalist and researcher, professor and chairman of the Department of Voice in the Faculty of Medicine at the University of Aconcagua, professor and researcher also in the Faculty of Arts at the University of Cuyo in Mendoza, Argentina. She's a member of the Sociedad Argentina de la Voz and executive member of the Asociación Cuyana de Fonoaudiólogos and member of the Council of Ethics Fonoaudiologists also. She's vocal coach at the University Choir of the University and Seniors Choir Amigos de Siempre. The next one, please. And Ana Gloria has, the next one, thank you. She studied music, guitar, and singing at the School of Music in the University Nacional de Cuyo. She has been choir singer in the college choir of the School of Magisterio at the University Choir of the University of Cuyo. Actually, she sings in the Women's Choir Feminas School of Magisterio. She's graduated from the University of Aconcagua and received a PhD in Pathology of Communication from the University of Museo Nacional Argentino. She developed a new technique for acoustics analysis of voice and electroglottography and works at the moment in her private practice with voice professionals. She published 2 books and many articles in the Faculty of Arts Journal. Thank you very much for the presentation, Ana Gloria. Let's enjoy.
wind instruments, whether woodwind or brass, produces different effects on the vocal tract and on the vocal folds, depending on the characteristics of the instrument sound tube, the type of embouchure, and the playing technique used. The resistance to airflow varies depending on the type of embouchure, open hole in the flute, single reed in the saxophone and clarinet, two vibrating reeds in the oboe, or mouthpiece of different sizes and depths in the trumpet. This produces a variable impedance effect on the vocal tract and larynx. Claudia Eckley, in 2006, in Brazil, she studied the larynx of 10 musicians while they were playing their wind instruments by means of laryngostroboscopy and observed a variable closure of the glottis depending on the tones produced. The larynx controls the airflow that reaches the embouchure of the instrument by interfering with the airflow through a variation of glottic closure. Therefore, wind instrument players should also be considered professional voice users. The objective of my research was to evaluate the effect of wind instrument playing on the vocal folds. 16 experienced wind players were evaluated, 6 oboists, 6 saxophone players, and 4 trumpet players from the oboe, saxophone, and trumpet department, School of Arts, National University of Cuyo. All of them underwent a laryngeal examination by rigid endoscopy, acoustic, EEG, and perceptual examination of their voices. The acoustic and electroglottographic tests were applied before and after playing the instrument for 30 minutes. The acoustic and EEG tests consisted in the production of the vowels E like in B and O like in hot in modal and falsetto registers with a centered position of the head. The results were compared with those obtained in a control group of 6 subjects without vocal training who underwent acoustic examination and EEG before and after 30 minutes of loud phonation. Here we have an example of acoustic examination. We examined vowel E in modal register before playing the saxo and after playing the saxo. And if you see the variables studied, you can see a decrease of the habitual frequency in hertz, a decrease of jitter, a decrease of shimmer, a decrease of frequency tremor, and an increase of sound to noise ratio and harmonic to noise ratio. And if we analyze those results, we may infer that after playing the saxophone, improves the phonation of the saxophone player, of this saxophone player. Here we can see the curves, the electroglottographic curves of vowels E and O before playing the saxophone and after playing the saxophone. And if you see the morphology of the curves, you can note an open face, very long open face before playing the saxophone. After playing the saxophone, that open face gets better, and we may we may infer playing the saxophone improves the vocal vibration, the vocal cords vibration. Our conclusions, some of our conclusions, or some of our of the tendencies observed. The oboe is more harmful to the phonatory mechanism due to the tension with which it works. It acts on the larynx through the resistance that the mouthpiece opposes to the exit of the air. EGG curves show a significant decrease in glottal contact. Oboe playing produces an effect on phonatory behavior from two stimulus sources. The airstream, which produces in the low tones tendency to glottal opening and the stabilization of the vocal fold vibration, mainly manifested in the shimmer. The second stimulus source is the impedance reflected on the larynx, which produces a tendency to a hyperfunctional phonation. The saxophone acts on a very low laryngeal position, protecting the phonatory mechanism. In general, saxophonists keep the larynx more stable in its position, in its low position. EGG curves tend to be more relaxed with a larger area in relation to the longitudinal axis. Saxophone playing produces an effect on phonatory behavior from two stimuli sources. The important lowering of the laryngeal position in pre-playing postural situation of the instrument, which acts for both low and high tones, producing tendency to glottal closure without tension, and stabilization of the chordal vibration, mainly manifested in the shimmer. The action of the air current produces a very important elevation of the frequency in a post-playing situation, but without tension. The trumpet acts on a strongly positioned air column, produces a stable lowering of the larynx, which favors the balanced regulation between airflow and pressure. EGG curves show slight signs related to mucosal erythema. An increased or decreased contact quotient is observed after playing. We conclude that although wind instruments produce certain effects on the larynx derived from the characteristics of the wind instrument, like sound tube, type of embouchure, and aerodynamic characteristics, the larynx reaction is influenced by its muscle condition. The instrument acts on the base chordal state. There is an interaction between vocal folds and playing wind instruments. Practical implications. An initial laryngeal evaluation is necessary for all wind players. Warm-up muscle exercises are necessary before playing the instrument. Those exercises involve tongue, jaw, and larynx lowering movements, and also abdominal contraction, such as the contractions we make when we make or do Valsalva maneuver. What happens when we work with a singer also plays instruments? It is very important to apply cool-down exercises. Cool-down exercises should be chosen depending on the personal characteristics of the player's voice. These exercises improve the laryngeal position, the glottal closure, and the mucosal wave. They utilize the muscles involved in phonation and singing. Any repositioning routine should include exercises adjusted to the characteristics of the instrument being played, plus specific exercises depending on the individual characteristics of each singer's larynx. Thank you for your attention.
Thank you very much, dear Ana Gloria. So as you see, this has been really a very complete presentation session, because we have had the advances in the laryngology applied, of course, to artistic voice that Jonathan Fishman showed us, and then the great research from our dear Roncher, showing many details that are very important because we have to be all the time hand by hand with research in larynx and voice. And then the education possibilities of the multidisciplinary group, as we know all over the world, is very important. And Jeremy talked about that in a very interesting way. And Ana Gloria showed us how the wind players, instrumentalists, can also have some laryngeal problems, and of course we have to take care about that. And now we are having the closing remarks. It's a little bit, I'm going to share with you some of our next situations that we are going to have in our CoMeT activities. And I am very happy also that Dr. Laura Dominguez from Hospital General de Mexico, she's a very special friend from me, and a laryngologist, otolaryngologist, very, very important. And has been also chief of the training department in this very important and big general hospital in Mexico City. So I would like to share with you, some of you know, about the great events that CoMeT membership had with different international congresses. First of all, I want to thank again our Professor Dr. Haldun Oguz with Ilter Denisoglu and Ahmed Genei, who organized this wonderful Union of European Phoniatricians Congress in Antalya at the end of April. And our CoMeT members made great presentation. Jacobo Karagama talked about superior laryngeal nerve palsy, very interesting. Then Silvia Capobianco, Western classical singing, and then some acoustic and EEG observations using rough effects by Julian McLachlan. Alfonso Borragan showed us the proprioceptive elastic method, and Ilter talk about extended vocal hygiene and vocal ergonomics in artistic voice. I talk a little bit about avoidance and neutralization of environment harm in artistic voice. Ahmed Genei about surgery for artistic voice, when and how, and some words about indirect phonosurgery in voice that I talk about. Then we had a great round table with many very important CoMeT members as speakers. Berit Schneider-Stickler and Joseph Schlomi-Hertier from Austria, Dirk Mürbe from Berlin, Ahmed Genei from Finland, Alfonso Borragan from Santander, Spain, Orietta Calzinoni from Milan, Italy, Matthias Echtenach from München, Germany, and Andrea Ricci Maccarini from Cesena, Italy. Thank you very much, because it was wonderful. I am trying to have all these conferences because they are worthwhile, that they also can be presented, not all of them perhaps, but can be presented in CoMeT session, and of course in CoMeT webpage, because it's a lot of work and it was very interesting. And then we had a wonderful, wonderful meeting at the 52 Symposium of the Voice Foundation, Care of the Professional Voice, with our dear, dear Robert Satalov, that he, as you know, he's a distinguished member of CoMeT and also the chair of the Voice Foundation. And we had great presentation with Sten Termstrom about talking self to other ratio revisited. And Reynaldo Yasaki could not come, but our dear Ron Scherer introduced us to Michelle Bretel. She is a predoctoral trainee, and she talked about very interesting topic, vocal instabilities in untrained female singers, and she gave us permission to publish that in our webpage. Our dear membership secretary, Isabel Garcia Lopez, talked about subjective and objective voice problems in opera singing students. Liza Popel, our dear Liza, she talked about the mechanism and art of vibrato. Wonderful, Liza. And our dear Alfonso Borragan talked about the rebalance of the phonatory system and improved vocal function through the proprioceptive elastic method. Ilter Denisoglu about vocal periodization, a muscle-specific approach for singers. I was talking about pre, peri, and post-surgical care in the artistic voice. And our dear Austin King, treasurer of CoMeT, he talked about when bad things happen to your voice, what is the problem? And we had also some comments about treatment of artistic voice. So it was a great session. And then we were invited by Voice Foundation organization, Bob Satalov, to have a panel from CoMeT members about artistic voice emergency. And we shall publish that also in our webpage with Isabel Garcia Lopez, with Pig Wu from United States, Liza Popel, and me. And we presented 4 different cases from the worst with hematomas and bleeding until dryness. Very interesting panel. And well, the next thing that we are going to have, and I hope you can enjoy that, is the 17th online session. It will be on Saturday, 23rd of September. Please note that we are now in holidays, some countries. That's why we make that on 23rd of September. Like to have CoMeT members are going to be present, and CoMeT is giving academic support to La Voce Artistica in Ravenna with our dear CoMeT member Franco Fusi. It's going to be from 16 to 19 November this year, and everybody is welcome to this great La Voce Artistica. Franco is going to be there as presenter, not only as president of the Congress, but also Erika Biavati, Eleonora Bruni, Alfonso Borragan, Andrea Ricci Maccarini, among some of our CoMeT members. And then we have 2024 PVOC in Santander. The president of this Pan-European Voice Conference from Spain, Santander, is our dear CoMeT member, Alfonso Borragan. And of course, we shall have many presenters and a CoMeT session with him. And everybody's welcome to come to Santander and enjoy that. And then we are in preparation. We do not have yet the date because it depends on the institution. But Dr. Eki Bianco, our dear General Secretary, is trying to prepare our next presential face-to-face Congress from the family of CoMeT. And this is going to be 2024. And 2025, like every 2 years, we are going to be in the Voice Foundation again with our dear Bob Satalov, and to have CoMeT presentation. And in 4th and until 7th of June in 2025, CoMeT is going to be present in the 31st Congress of the Union of European Phoniatricians in Prague with our Professor Jan, that he is going to be the president. I shall let you know after that. And in 2026, Isabel Garcia Lopez and Cory Casanova from Spain are preparing Madrid. So, you know, we have a lot of things. Please think, and I don't know, Isabel, do you want to speak, please, about our CoMeT webpage and the update of personal data of membership? Isabel?
Yes, hello. Thank you. Can you hear me?
Yes, we hear you.
Yes. Thank you, Jenny. Thank you for this presentation. Just to tell all of you that you are going to receive a letter from Eugenia, from our president, because regarding the data in our website, we are working in putting the website more
Complete?
more actual, and we're reviewing all the so the name of all the members, the addresses, the emails, and so on. So we would like that all the information that you will put in our website, we want you to send it to us in order to update all this information in our website. You will receive this letter, and that's all. Thank you.
Thank you. And Erky, would you like to say something about Paris, or you don't have any notices yet?
No, I'm going to have information next week, so I tell you after.
Okay, thank you very much. And so please do not forget, we have now the bank account in by the treasurer place, that means in Abilene, Texas, where Austin King is living. As you know, the bylaw says that the bank account has to be where the treasurer is. So we changed the bank account. If you have already paid to Austria Pay account, do not worry, please send us the payments. And don't forget, you have to have your CoMeT fee this year. We are a little bit late, but because of this change of bank accounts, you may pay by PayPal or by bank account, but it is in the States, and send us. And if you need an invoice, please let us know. Austin King is going to take care of that. He sends many greetings, but he has just come back from Greece, and he was flying from Greece to the States, so he had no possibility to join us. And another thing that is important, please take care of committees. The History Committee is led by Dr. Austin King, because perhaps some of you know that Dr. Perello, Dr. Van Lawrence, Dr. Wilbur Gould, they gave many information to Austin King, so he's taking care of this History Committee. But everybody who has something to add, like photos or whatever, please feel free to contact us, and we shall have the history of CoMeT, because really it's worthwhile. And Marco Fantini is going to organize the social media. We do know not everybody wants social media, but we have to keep on with the modern world. And of course, I need some volunteers for sponsorship. The persons who are in the States, who are in Europe, or who are in another countries, if they have contact to the industries, pharmaceutical industry or equipment industries, please talk about CoMeT and let me know if you have these contacts, so we can have some sponsorship, for example, for webpage or for some other things. So all members are invited to participate. And I was thinking about a roundtable talking about medicines, which is our experience, and of course some background about the pharmacological effects on the voice that our dear Wolfram Seiner had made a lot of research about that many years ago, but we have also some experiences about that. So I thank you very, very much. And as you see, we are going to be very busy also in the next years. And of course, we have now the live discussion, and the presentations of today have been really great. And Catherine Newman, hello, my dear Catherine, liebe Catherine, great that you are here also with us. And we shall talk about in the live discussion about these 4 presentations. So feel free if you need to go. And I thank you very much. I know the times after the pandemic are different, but I think to be in touch with you 3 or 4 years or 4 times in the year and hear about your work, your experiences, and of course the live discussion without any time limit. Well, I enjoy that very much, and I hope you enjoy also. So I thank you very much, and let's go with live discussion. And the first presentation is with Jonathan Fishman, that, as you know, he's a new member invited last year, 2022, from our dear friends, Dr. Jürgen Ruben, and when I am not wrong, Dr. Ruth Epstein also. Yes, Jonathan, and I congratulate you because I think to summarize what is happening in the 10 last years in laryngology, and of course applied to artistic voice, is very, very important. And I had a question before I open to everybody about your experience, if you have some experience about these stem cells in difficult cases of singers or actors, if you have some experience about that, Jonathan.
Thanks, everyone. Once again, it's good to be here. I don't have the experience of actually human clinical trials for stem cells. So the regulation in the UK is very strict, and that's been one of the main sort of problems translating any research into sort of performers. We have sort of preliminary data in animal studies. I think the main problem with the stem cells is survival and rejection. So unless you're using the patient's own stem cells, we face problems with the immune system and the cells will get rejected. So I think it's clear that any use of stem cells would have to come from the patient themselves, and we call those autologous stem cells, and they would usually come from the bone marrow. And Stellan Hurtigard, who you may have heard, he's based in the Karolinska Institute in Sweden. He is a laryngologist, and he has done a very early phase clinical trial in patients that have vocal fold scars, injecting into vocal folds to assess the really safety of stem cells, because there's still a lot of controversy, I would say, about stem cells. What do they actually do and how safe are they? And it's fair to say that it's only a small group of patients, and really it's just assessing the sort of safety aspects of the cells. He doesn't have control groups, and I'm not aware of too many human, unless someone else says, any human sort of trials, large human trials going on currently in the world. But I think, you know, it does hold potential avenues for the future. I mean, we do see patients, I mean, I get referred patients that have had maybe surgery that's gone wrong in other institutions. And I work in a big sort of national centre for voice in central London. And we see these heart sink cases where patients are being operated on, or they've had sort of stripping of vocal folds, which really shouldn't happen nowadays, but sadly it does. I've seen sort of 2 patients in the last 6 weeks, I would say, both of which had benign pathology, and they've been sent to me and they've had their vocal folds stripped. Fortunately, they're not singers, but even so, they're still professional voice users. And, you know, when they come to you in that situation, it's a very difficult problem. You know, our speech and language pathologists can't really do much with them. Their epithelium, their mucosa is just scarred down onto the ligament. They've lost Rehnquist space. They have an absent mucosal wave on stroboscopy, and we need to start thinking of ways we can help these types of patients, either with new injectable materials or regenerative medicine approaches.
That's very, very interesting. Does somebody from the audience want to ask something or make some comment? Because 10 years, it's a long time, and we have learned a lot of things, but also we do not accept now many things that we thought we knew. So knowledge is very, very active, and I think we had the opportunity to live a very special phenomenon, and that is COVID time and pandemic. And somebody from the audience has something to comment or to add? Yes, Ana Gloria?
I want to ask Dr. Fishman if he knows anything about the properties of the new injectable material called Radiesse. R-A-D.
Radiesse. Yeah, Radiesse. No, we're very familiar with Radiesse. This is made by a manufacturer called Mertz. It's a calcium hydroxyl apatite material, so like a sort of chalky type substance. And actually, we're having supply chain issues actually with this type of material. So actually, Mertz that produced the Radiesse don't actually make it anymore. And it's another company called Soluvols are the distributors, but it's called Renew Voice. So we actually use something called Renew now, R-E-N-U, but they're all calcium hydroxyl apatite. The problem with these materials is they work really well for patients with vocal fold immobility and paralysis as an augmentation material, but they're not. If the problem is, if you get this material into Renke's space, you end up with a stiff vocal fold. So for conversational voice, this is adequate, but for sort of our elite performers, I wouldn't say it's sort of an optimal material. And it's essentially just a sort of stiff filler material that we use to plump out a vocal fold when it's immobile or paralyzed to help it to meet the contralateral cord. But it is one of the materials that we do use for vocal fold paralysis. Yeah, and I use it as well. I find it particularly good in palliative cases, actually.
Yes, and
Cancer,
I
yeah.
have heard from some other colleagues that radicin, so hydroxyapatite, has produced some granulomas. So this is, so I am still very conservative, and I only inject fat. I don't know if you can make some comment about that, Jonathan.
Yeah, no, I totally agree. I'm a big fan of fat and also hyaluronic acid, so the softer materials. So I put in my presentation about jellyfish collagen. So I'm meeting these researchers actually next week to discuss that. It's not been used in the human larynx, but it's meant to be very similar to human collagen.
Yes, the thing I was thinking, because I have just read an article about jellyfish allergies.
Oh, okay.
It's a very big group of, I think it was made in the States, but I haven't read it completely. But, you know, in the families of the animals, some jellyfish has a lot of things to do with shrimps and lobster and things. So when you said about that, I was just thinking, well, it's interesting, but I don't know.
Yeah, I mean, this is the problem.
We have to stay with the animal human being.
Yes, I mean, this is the problem in the field, that we don't have an ideal material, certainly as an injectable material. And you're right, the jellyfish collagen manufacturers are really sort of pushing it, but like you, yeah, of course, we worry about allergies and things like that. Yeah.
Yes, right. And somebody, yes, Ron, sorry, I didn't see you. Yes, Ron.
Couple things. It seems that if you catch your own jellyfish, it'd be a lot, lot cheaper. I do have a clarification question, Jonathan. I was not familiar with laryngoscopy where there's aerosol generation without. Could you explain that a little bit more? What aerosol generation is?
This was with the COVID work, wasn't it? COVID-19.
Yes.
Yeah. So during laryngoscopy, most of the risk of aerosol generation, it was felt was going to come from the patient coughing or sneezing during the laryngoscopy examination, or even phonating, actually.
I see. This is aerosol
when we're getting them to actually phonate.
Yeah, this is aerosol from the patient, not
correct.
to the patient. That was confusing.
Correct. Yes, exactly. But actually, what's really interesting is there's been a complete U-turn, a complete turnaround. So in 2020, you may remember at the start of the pandemic, everyone was like, uh-oh, shut down, no laryngoscopy, the risks are big for COVID spread. But actually now, if you look at the literature, the converse seems to be happening. So actually the risk of aerosol generation from a laryngoscopy is very low. Good. Which is reassuring for future pandemics, I would say.
Yeah, one of the problems we had, as you know, was using extra masking on the face and for less intelligibility. So it's difficult, even in the OR, I guess, to understand some.
Yes, we have the same. But we've learned so much, I would say, over the last 3 years or so. So if there were any future pandemics, which could happen, influenza and so on, then one hopes we'll be a lot more prepared.
Yes, that is not so easy, but I think in general, all the persons, ENTs, laryngologists, phoniatricians, special language pathologists that are making laryngoscopy, they have to take care, because it is not only SARS-CoV-2, it's also influenza, it's also staphylococcus, streptococcus, and all the microorganisms that are living with us. So we have to take care about that. And my advice now to the patients is, please, when you are in a risky situation, please stay with your face mask. And of course, I am very strict in my praxis, because everybody's singing, because I need to examine singing. And I am still with my face mask as astronaut, because I don't want to be sick. Anyway, but it is interesting that how we change, because on one side we have long COVID problems, and on the other side, aerosol seems not to be so difficult now in the laryngoscopy. I don't know if somebody has. Yes, Jonathan, you can please comment something, or somebody else, Catherine Erkey.
I mean, I was going to say there's so many variables: temperature, humidity, airflow, even the sort of intensity of their singing as well. This would all affect aerosol. So you're right in that sense that, you know, if there are risks of more aerosol generation, particularly if the patient sneezes. Sneezing has the highest aerosol, in fact.
Yes, Jonathan, and I was very interested in this is optical coherence. How does it function, optical coherence? Because
it's basically like a non-invasive imaging technique. It's actually used quite widely, in fact, in the eye when they're looking at retinas. But essentially, it's a sort of light technique, and it allows you. It's being used again. It's sort of a research tool, but it's being used to look at sort of vocal folds to try to assess them. It's a bit like NBI and other forms of imaging, narrowband imaging, where you can sort of assess vocal folds and lesions, potentially avoiding biopsies in the future.
Okay, thank you. And let's go to the presentation of dear Ron. Ron, I enjoy that really very much. The modeling is just great. And I wanted to ask you about the rarefaction of the glottal flow, because as we know, mainly according to diseases, we can have changes in the glottal flow due to bronchial problems or lung problems. I don't know if, I know you are modeling and you are making research in all these physiological aspects, but I want to apply them to clinic, and I don't know if you can comment about that, because I found that very interesting. The small changes that you show us, they are really interesting.
Well, I would say that the function that I mentioned, which is the rarefaction that occurs above the glottis when the two vocal folds are coming toward each other. And when the vocal folds go out, actually the flow is actually sucked in just a little bit in a sense, but it's coming from below. But when you're shutting the flow off, it's like turning the faucet off. When it's maximum flow and then you turn the faucet, there's less flow and then there's less flow, and then there's no flow. So when the vocal folds are coming together, they're shutting the flow off, meaning that the volume velocity is decreasing. And that means that at time one, the air particles are coming out at a certain speed. But a little later, right before the folds close, they're coming out at a less speed. So that slower speed makes these particles separate because the ones up here are going faster than the ones up here going faster than the ones down here. It's not good to do this and try to talk about what's going on, is it? So what that does, it creates a negative pressure, and that from a physical acoustic point of view, that actually is the primary acoustic excitation of the vocal tract. It creates a fairly large negative pressure, and that excites the resonances of the vocal tract, and it rings, and from cycle to cycle to cycle, you get a vowel. Now, so that's just a physical aspect of good closure. If there's not closure, that effect is less, so the sound is different, etc. Connecting it to something that is a respiratory problem is a little difficult. If there is less subglottal pressure, then there's going to be less airflow, and that's going to create less of a rarefaction. The higher the subglottal pressure, the greater will be this rarefaction, and that's why subglottal pressure is related to the loudness or intensity of the sound. So if you have a problem in creating subglottal pressure, which often we obviously do have, the sound is less, and that rarefaction, physical rarefaction, is less. And that's the primary physical aspect from a tracheal and below situation, generating subglottal pressure. Now, if you have problems with the vocal folds, then also that messes this up too, because then you don't have normal closure. You may have a polyp or something, and in fact, with a polyp, you've got now two lines of flow when the folds are close together, because it looks, like this, before that they can't touch, things like that. And so anytime you mess with the airflow shutoff, you're going to create a different kind of sound. And because from an aeroacoustic point of view, it changes that situation of rarefaction and that situation in that region. So I guess to answer your question, the primary problem would be the creation of subglottal pressure, and then anything at the larynx if you have a large posterior glottis or something like that. But that's no longer respiratory.
Somebody from the audience want to make some question? Yes, Liza?
Hi, Ron.
I would say.
A little bit louder, my dear.
Okay, let me make sure that this is that
Louder,
I have
louder.
audio. It always defaults low, and okay, there we go. Is that better? So, Ron, I wanted to just continue on what you just said about how the sound might be affected by. My question really is, how might the sound be affected by asymmetrical movement? Might it be heard as roughness or hoarseness? Just like having a polyp results in a change in perceived hoarseness, roughness?
Yeah,
so-
this is a great question because there are two kinds of possible dichotomous responses first for this. One is here is symmetric motion of the two vocal folds, mirror images, get normal phonation. There's opening, closing, and then closed, and that could be a certain percentage, normally from 30 to 40 to 50 for closed quotient, right? Now, there are, if you can have an asymmetric motion of the two sides that are not mirror images, but they're out of phase with each other, and this can result in normal sound, because notice when I do this, notice that the folds are separating and then coming back and separating. So now there's more flow and then less flow, more flow and then less flow. And if that cyclic action is the same from cycle to cycle, the flow actually might be quasi-normal. It will be a little softer if there's not much contact, because when the flow comes down, there's going to be kind of a rounding of the corner there and less energy to higher frequencies. But you can have a normal sound that way. And this is where, and I'm sure the MDs in the group here can see this with stroboscopy, high speed. And now the other aspect of that is when one side has more mass or tension than the other side, and especially if they are not coming together, but are vibrating somewhat apart, their natural frequencies are different. And they will vibrate at, this might be faster and this might be slower. And the further apart they are, the more you'll get a diplophonic two frequency creation. But if they are close enough, even though they may differ in mass or tension, the closer they are and the more they come together, they will tend to entrain to a frequency that's kind of between this one and this one. And you might get a pretty good sound. However, if they're not that way, and this is without a lesion, it's just tension, okay? Tension and, well, if you throw now a big mass on there, then you have other kinds of strange modes that are going to happen, and you get a rough voice. So the first modulation is going to be the basic frequency with a lower frequency on it, like we see often in creaky voice and sometimes vocal fry. So the idea is that's going to chop the air differently. And as it chops the air differently, you get the frequencies like I was mentioning, and it becomes a hoarse voice. Or you get noise characteristics because there's a lot of airflow. And you can also have chaotic motion, as you know, where now they just can't vibrate well. And you get that little noise like during register breaks, or people, I don't go like this, it's a lot of, well, actually I'm using false folds or something, So I have these different sources of sound. It's related to the noise or distortion work by singing creation. That
Yes,
makes
Erky?
sense.
Oh, yeah, it's fascinating.
Yes, Erky.
Yeah, when we made a high film on very top grade opera singers, all of them had a symmetry with high speed camera. So one chord was opening in one cycle and the other one was closed, and then it moved like a hula hoop effect. All of them had it. And the more they had it, the better the voice was. And
The more they had what, the better the voice?
Symmetrical, in high speed, you have this asymmetrical circle. And then it was the best singers in the world.
Yeah, there you go.
Does somebody else want to add some comment or question? Yes, Soledad?
Hello, Soledad. Soledad.
Thank you for your explanation. It's wonderful, but I would like to ask you about another conversation you have for CoMeT. It was about vocal fry. What do you think about using vocal fry for relaxing the larynx? Don't you think it's harmful in some way? The phase, when the closing phase is prolonged by an 87%. What do you think? Do you have anything written about?
Yeah, vocal fry, as you know, is a normal register, and it's non-injurious in speech, end of phrases, when it's soft and all that sort of thing. So vocal fry is a very low pitch. So from a physiological point of view, quite often for vocal fry, the CT muscle is not much activity, but often vocal fry has a fair amount of adduction. And so the adductors, LCA, lateral TA, interrytenoids, could be contracting a fair amount. And so the bad news would be that it's an imbalance. It's not normal phonation, so it's low, it's going to be rough. It has a wide range of different kinds of motion, 2, 3, 4, etc., kinds of contacts. And we have actually published on those kinds of things. So the bad news might be that fatigue because of hyperfunction of those muscles, fatigue at the end of the day, so to speak, might be one thing. I'm sorry?
Supraglottic hyperfunction.
Yes, if you have also accompanying perilaryngeal, false folds, upper portion of the lateral TAs, if you have narrowing of the hypopharynx because of muscle work, that's more in the strain area, basically, of phonation. But quite often people vocal fry without that, and so you have these muscles. So the bad news is that you might have fatigue, but the good news is actually that, as you may know, it's vocal fry is used often to enhance the voice. So if you want to relax the CT, vocal fry, but do it softly. If you want to strengthen the adductors and correct an abducted larynx, you can have the person vocal fry and for a certain amount of time so that the adductors are actually building up. This is the same as having the person practice same sort of deal where you practice adduction, raising the tone of those muscles so that when they go to speech, there's better closure for those with kind of abduction. They need to exercise those muscles. Relative to vocal fold tissue damage, I don't think that there are many studies that indicate that something like nodules or polyps, even swelling to a certain extent, really exists with vocal fry, unless it's low pitch, obviously, and loud, and with a lot of subglottal pressure and a lot of contact force. But I think it's fairly rare.
But no, would you use it to relax the larynx as an exercise?
As a matter of fact, actually, I do use hyperclosure when I have fatigue. When I find, like, after Eugenio will understand this, after 4 days at the Voice Foundation Symposium, you get a little tired. Lisa knows this too. And my voice I have a little bowing of the voice anyway, of the vocal folds anyway. So I'll get fatigued. And the way for me to get out of that is to vocal fry, do a hyperadduction, build up a little more tone in those muscles so that the sound is more like what I'm using right now. Yeah, I don't really. So usually there's a dichotomy in speech path that we talk about. Maybe Jeremy will support this, that there's two kinds of fry: the normal fry, low intensity, end of phrase. There's more in some languages than other languages and dialects and all that. And it's almost never injurious. Then you have people who vocal fry a great deal, low pitch, driving, a lot of muscle tension. And this can lead, and if there's reflux on top of that, then you're really in trouble, right? And you might want to comment on
In
that.
guttural singing, you said, no?
I'm sorry?
In guttural singing, for example.
What kind of singing? Somebody else.
Guttural,
With volume.
like vibes like Ricky and vocal fry, creaky growl, there.
Oh yeah, creaky voice. Yeah, creaky voice is in our lab. Creaky voice is you have a higher pitch, but then you have a roughness to it with a kind of a fry on top, which is a modulation of that higher frequency. So if I talk like this, I have this but I have this on top of the so I can talk like this little old guy and always have to have a cane in my hand. And yeah, so that's creaky voice to us, but not to everybody nowadays. Yeah, I don't know if that helps at all, but vocal fry is if you abuse vocal fry, it's not good, but it's not as dangerous as some people think.
Well, it's another topic, but I just want to close this vocal fry with my experience that as relaxing, I do not accept that. To improve when you are, like Ron says, after 4 days of voice foundation, of course, it helps. And also I use that very much with vocal fold paralysis, mainly unilateral. And of course, you can use it in some singing effects, but not as relaxing. But
Yes.
anyway, we shall do something special for vocal fry. And now, yes, Catherine, please.
Thank you.
Sorry for being so late. I wanted to add something to the vocal fry story. If you remember what Ingo Tietze wrote, that it is a perceptual register. He separated perceptual from registers from those which you really produce by another kind of voice production. And he said there is nothing differently produced, but we perceive it because we cannot. We do resolve pulses, glottal pulses, which are below 70 hertz as single pulses, and therefore we have this impression. And I agree with Ron that there is, if you use it in a natural way, there is no way to hurt or to damage voice production. I have an example from a singer. If you want to hear it, I can share it. But if it, yeah.
Is it short?
Let me see.
Because we have still 2 presentations. Okay.
Probably, you know, okay, oh, excuse me, this was the wrong one. I guess this one. Can you hear it?
Yes.
Gotta walk that long, so
This is vocal fry.
Yes, wonderful.
gotta walk that long.
And so on. Okay, stop it.
Okay. Thank you, Catherine.
Okay.
Yeah.
Yeah, but it is. I agree with you. If you are making that in a proper way, it's okay. But sometimes it's an abuse of vocal fry. But anyway, we shall change subject because it is not.
I need to make one comment first.
Yes.
The 70 hertz thing is that was an experimental aspect and also consistent with some earlier research, but it's not really true, because you can phonate much lower without going into fry, depending on who you are. my larynx, for example, I'm probably, that's 100 hertz right there. So if I talk here, this is not vocal fry. 1, 2, 3, 4, 5, 6, 7, 8, 9. But that's about 65 hertz, 60 hertz. And it depends on the larynx. So,
But I hear the
so by
single pulses, Ron. I hear your
yeah,
single
but
pulses.
with a little breathiness, it doesn't have the pulses because it doesn't have a close time. Yeah, so we have this problem as we have with all registers, right? We have the actual production, then we have perception, we have a definition, and then eventually we change it because we understand the production better.
Thank you. So I would like to ask Jeremy about the difficulties that he has had in all this organization with the students, because there are many students that are very eclectic to go to the examination, and they think they know everything about what is singing, what is acting, because they have a natural talent. And also another thing that this is the second question about hearing, because I do think in all these students, you have to take care of hearing also. Yes, Jeremy, can you please comment about that?
Yeah, great question. Let me answer the second one first. That is something that I forgot to put in that presentation. So in each of our screenings, we do a hearing screening as well. And then if there's any concerns there, then we refer them to our audiologist. We also, with the music department, I don't know that right now we have anything formal in the theater department, but in the music department, we do have our audiologist and some of our graduate students go over and talk about hearing health with the music students. And typically that's the entire music students rather than just the vocal music students, which is who I tend to get to talk to more frequently. On the voice side is those that are in the voice department or the choral music. As far as the tell me again your first question, I'm sorry.
Yeah, difficulties from the students to understand that they have to go on the screening of the professionals like you, like laryngologists and audiologists, of course, singing teacher and acting teachers. While the actors are very difficult, the theater actors.
You know, I've been really thankful for the people, my colleagues in the other departments. They really push vocal health and they really push the vocal screenings with their students. And interestingly, the compliance probably out of the theater department, I have found to be higher than the compliance with the vocal music department. I think some of that may be that that a decent number of the students coming into the theater department don't have as much vocal experience as the singers do in the music department. But I also think that my colleague Lauren Weber, who has completed the vocology program, I think she's completed the vocology program through National Center for Voice and Speech, is really good about plugging the need for the vocal screening. Now, all of our vocal screenings that we offer to the theater department and the music department, those are voluntary. The students are not required to have those, although we try to plug the importance of that and help them see how a free laryngoscopy is potentially a big deal, right? And we have most of the students that sign up then do come. Now, if they are identified as having a vocal problem and they start voice therapy, I think that's probably where I see more of the concerns of those that do feel like they know what they're doing and don't necessarily need help. But a majority of the students who do come for voice therapy are very receptive. Though obviously we have had several since I've been there that they are coming only because their voice teacher tells them to come.
Yeah, because there are many universities and in Europe, and we also have that in Mexico, that we require an beginning and the first examination before they are accepted in the universities for music or for theater. Unfortunately, in Mexico, when I came back from Vienna in '82, I saw the ideal examination in Vienna. And the ideal examination is not only music, of course, but also all the phoniatrical examination with the larynx and also hearing and of course nose. And I don't know, in your group, do they have this idea, or the university, the Baylor University, do not give so much attention, or which is the experience in Baylor?
All of the students have to go through an audition process, right, where they sing and their voices are listened to and such. But as far as a requirement for a laryngeal or acoustic exam, actual, acoustical examination, that isn't required. And I don't know, I mean, I'm not familiar with all the universities within the United States, but any of those that I've looked at have not had a requirement for a laryngeal exam prior to beginning their studies. If anybody else knows something different, I would be very interested to know.
Yes, because when I was studying in Vienna and all over Europe, they have this ideal examination. I don't know how to say it in English because it's like idoneity, or that it is very that you are ideal for having this career, and so they have the musical or acting talents, and of course body health has to be also examined, but very, very special all the voice examination from a specialist. For example, in Berlin, they come to the hospital, and this has to be by law. It's not that they want or they do not want. If you want to apply to go into the university as for singing or for acting, you have to have this examination approved. And usually it is made by laryngologists. I don't know, in Münster, Katrin, you have the same, don't you? Tauglichkeitsuntersuchung. Tauglichkeitsuntersuchung. Yeah.
Yes.
Yes, and I think this is very, very important. So I hope, Jeremy, you can put it in Baylor.
Yeah, it's very interesting. As far as I know, no one in the United States requires a laryngology exam before admitting into university for theater or voice. Ron, do you know anything different?
Yes, Ron?
No, just that it's traditional some places, like Bob at AVA, but that's different from your situation.
Yeah.
Yes, but because, as you know, our dear Katrin, with dear John, and some of us are helping, Katrin has shown to the WHO a great interest that WHO in the future could take the voice as also a special package of rehabilitation. And for example, this situation is important that also all the universities know which is the transcendental thing to have a examination, because we are the group of phoniatricians, laryngologists, ENTs, speech pathologists, voice scientists. We are a big group in the world, and we are having a lot of experience and knowledge about the voice problems. And I think to prevent voice problems in the universities, you have to have this. So this is great. Anyway, I made an announcement for Katrin. Yes, Ron, you were going to take.
Yeah, just a quick question, Jeremy. Do you have at Baylor? Do you have undergraduate and graduate? Do you have actually a master's over in music, a master's in vocal pedagogy? And do you go over there and give talks on function and health in those courses?
So not within the courses directly. I have had the opportunity a couple of times since I've been at Baylor to go over and talk with all of the freshmen that are coming into the music department about voice in general and vocal health and voice disorder prevention. As far as within the vocal pedagogy department or the vocal pedagogy classes, at this point I haven't. We have a couple of colleagues over in that department that are really skilled within or really knowledgeable within the vocal health side. Although it is something that I've been talking with a couple of the voice teachers over there to see if I can get in and talk with them, either ideally within one of those courses as you've talked about. Interestingly, the vocal music department hasn't been as easy to get into to talk to overall students. And I think it's because of their schedule. Whereas I think the theater, the way they have designed their program as far as students coming into the program, there's a time where all of the new theater students are in a course together that then fairly easily allows me to come in for an hour and a half and talk with them, or an hour and talk with them. But a couple of my colleagues in the music department, I am talking to about the potential of having those opportunities.
Seems like Baylor, if you were to have better connection with music, maybe would be a fine institution for a very powerful vocology track.
Yeah, and it's something we've talked very briefly about, but we haven't talked really heavily yet.
Yes,
Yeah.
this is very important. I think the education, prevention, and promotion of all the knowledge, because as we know here in CoMeT, we have today samples of how can we have all the knowledge together in order to understand more and to be more scientifical in the way we are thinking about physiology. And this is great, Ron, that you say, well, you say what you want and I make the research.
But Baylor is special. It has amazing music programs and theater programs, and because of that, it could be a really leading force in creating these programs that heighten everything you just said, Eugenia, and the vocology and all that. But you have to have the right people, and you have to have the right academic curricular change.
Right. I think one of the other things that's been exciting for the speech pathology side, and that I forgot to include in the presentation, most of the students that I supervise don't have a music background, don't have a vocal background. So they're going through the voice clinic as a normal rotation. And as I've developed deeper relationships with the theater and vocal departments, then my students are getting the opportunity to go into some of the voice lessons and some of the vocal studios and learn what it is that the music students go through, and learn what voice instruction is, which other than that, they don't have an opportunity to do within their master's degree. So
yeah, that's great.
Dear Ana Gloria, I would like to ask you if, because you were telling us in your very nice and interesting presentation, I understand your presentation is a part of a big research that you made about the exercises that you say to the wind players about cooling down. Which exercises are you practicing with them, or are you advising to make? You are mute. Microphone. Yes. Yes.
Some of them are about the posture of the larynx. making movements with the tongue or making movements with the jaw, this kind of movement.
But to cool down, do you make some
Pull down,
voice
if you pull down the jaw, the larynx goes down and you relax the muscles involved. This kind of movements, and then in this position also, and in this position, or movements of the tongue. You put the tongue that way, and you I cannot speak in English.
No, don't worry. But I think I understood.
I show you.
But this is cool down, because I understand.
Yes, this is cool down.
Because if you make
you
effort and release, perhaps it can cool down. But usually what we use in voice is to make low pitches singing, and of course having all the relaxation from the joint, the temporomandibular joint, relaxation from the tongue. But if you are not making voice exercises, you are not.
No, they are not. No, they are not. They are not voice exercises. They are muscle exercises that act on the voice. You may also act on the voice without voicing. You understand?
Yes.
Those exercises act on the voice without voice. There are many warm-up exercises.
No, but I'm speaking about cool down.
Many warm-up exercises, muscle exercises without voice, and they act on the voice. And the same way, there are many muscle exercises, cool down exercises, muscle exercises or breathing exercises that act on the voice, cooling down the voice.
Well, and what about
euthanizing? I want to euthanize. I want to euthanize. I always do that. I want to euthanize all the muscles and all the muscles involved in the voice production, intonation. They can also make this one. After playing the trumpet or or anything they play, and the voice becomes better. The voice improves. The voice improves.
And what about oboe? Why do you think in your group
yes,
was more damage for the larynx?
Because it works with more resistance on the airflow, so it produces hyperfunctional phonation after playing the oboe.
Does somebody has comments, Ron? You have comments? Catherine? Erky?
Yeah, I have
Liza.
I have an
In
example.
Spanish.
We had a music student who was dual major, singing and oboe. And she came to the clinic with the greatest muscle tension we've ever experienced, because you would touch her right here and she would do that. She would, even when she touched herself, she would have great pain. And so I saw her recital, and it turns out that she's a better oboe player than singer. But we couldn't do much with her because it was so severe. So we sent her to PT, and physical therapy was, the approach. We didn't follow her, but she was the extreme example at our university of this great tension playing oboe, generalized to the singing and just in general the body. So she was in a lot of discomfort most of the time.
And in your group, did you also examine flutist? So flute?
Flute,
Flauta.
flute.
Transversa or normal?
Flauta traversa.
Yeah,
They
transversa.
have breathy voices. They always have breathy voices and breathy singing. It is very different. The man who I presented in my presentation, he was playing an ocarina. That's the name of the instrument. And those kind of instruments produce a different effect on the voice, breathy voices.
Those are the flute players, or the wind over holes players?
Yes.
Is that because they use so much airflow all the time when they're playing?
Yes.
So they get used to a more abducted larynx anyway?
Abducted larynx.
How do they balance?
The posture of the larynx, the posture, they abduct. Then they put that posture on the voice.
Yeah, so flautists, they manage airflow primarily by laryngeal adduction and abduction. Is that correct? Because they have to have the vocal tract open, or do they modulate air by motion of tongue or vocal tract creeping?
They make something with their vocal cords to produce the airflow first. So it is very important to see how is the muscle tension because of the glottis, because it acts on the airflow and on playing the instrument. And it is different. Do you know flauta de pan or siku? ¿Qué hace?
I think we say pan flute in English. Is it?
Pan flute.
Or harmonica?
Harmonica, it's different. Harmonica.
Harmonica.
It's different harmonica. But quena. Flute, flauta dulce, we say.
So how many instruments did you examine?
I examined 16 different instruments, 3 trumpets, saxophones, and oboes, and 2 clarinets.
Okay.
Yes, that is flauta dulce.
Oh, yeah.
Recorder.
Yeah, we know that.
That is a flauta
Catherine,
dulce.
do you have some comments or questions? Serki, Soledad, Andrea, Liza, Jeremy?
I have a comment
Yeah,
about.
Liza, I don't hear you. Please, louder.
Oh,
Your
I-
micro.
it should be, oh no. Oh, it shut off. It shut
Yes.
off
Ahí está.
by itself. So sorry.
It is perfect.
Okay, so about the oboe, I have one student who is a semi-professional oboe player, and though she doesn't have a lot of extra muscle tension, she's used to over pressurizing the vocal folds, which creates this stiff vocal fold. And I've worked with her for years. It's hopeless. It's better, but hopeless, really, because the chords are so used to being stiff and doing that it sounds almost like a duck or and it's hard to do vibrato when the chords are. So I have her just have terrible posture, relaxing, the opposite of what I normally teach, just to get a usable sound out. So it's that was my one and only, and I'll never forget it. What a challenge it has been.
Does somebody else has a question for Ana Gloria or comment? Because I want a quick question before we end to Ron. Ron, do you think with the comment of Erki, because I have seen the same as Erki, that sometimes the wave is not exactly the same but different, but even though that happens, what I have seen, not all the time, but they are very, very well trained opera singers, lead singers. So I was wondering during your presentation, if we could do something about making the convergence and the divergence in a different way with exercises in order to manipulate and have better physiological activity in the wave.
Yeah, that's a really good question. I'm sorry, someone wanted to say something?
No.
Yeah.
Yeah.
Yeah, so the really good singers will have closure, even though the two folds are out of phase, but there'll be good closure, and it's a closure that's really important. But to try to then somehow manipulate the larynx so that at all pitches, they are mirror images. Quite often with this is the case, the lower pitches might be more, lower pitches, I went down with my hands for lower pitches. That was funny. For lower pitches, there may be more mirror image. And then for higher pitches, there may be a little difference because of a little tension difference or configuration, or one arytenoid might not be exactly set like another arytenoid. And so that will change the vocal fold posture, as the word today's been. That's what I would suspect, by the way. But as an exercise, that's actually very interesting. I could see where you use a flexible scope and strobe, and then watch to see where, say, in the pitch range or intensity range, an asymmetry starts to creep in, and see whether or not that is sensible and changeable. But I've never heard of this kind of therapy or whatever. And nobody would know it if the sound was really, by Anna, would be really, I have no idea what I was going to say because you just said goodbye to Anna. Yeah, so that's kind of novel, actually. So if the sound is really good, you might not discover it. But my guess is that some pitch or condition, the system might break down. You don't have the sound or the intensity, the quality that you want. And that might be a limiting factor for people with, especially if the asymmetry is large.
Yes, Catherine? Catherine.
I
Anna
didn't want to ask a question.
Oh, she's not, Anna's not saying goodbye. She wants to make a comment.
I was sneezing.
Yes, Catherine. Nothing?
No, nothing. I wanted to I could add something to the symmetry and asymmetry story and to the breathing story in brass instruments. What we know is that they make the same movements with their vocal folds and have the comparable tension as if they would sing during the play their instruments. And if they have a higher resistance to phase, for example, in oboe, they can have so much tension that we sometimes have to forbid musical students at the colleges who study both singing and a brass instrument to, one of both. We say make a rest in your brass instrument playing, and so. And you can see it very nicely if you look with the scope into the larynx during they play their instruments.
Thank you, Catherine. Anna, would you like to say something? Ana Gloria?
Yes, I wanted to tell you about the exercises we make with asymmetrical movements of vocal cords. We examine asymmetrical movement with perceptual examination or with electroglottographic or whatever, changing the position of the head. The patient phonates in the center position of the head, to the right and to the left. And if you hear me, I have an asymmetry of my vocal cords. And if I say e, o, e, o, did you hear the differences? Well, today they are not very asymmetrical, but we teach the patients to work to decide the voice is better. Always to decide the voice is better, and we may work with this position too, also, and we choose with the patient.
Okay, but talking about asymmetric. Okay, dear friends, so
What about
we need to go, and let's not forget about physiology, because physiology is very important. We cannot change the physiology so easily if we do not have research like Ron. And of course, we can discuss a lot of things, but we have to be a little bit more technical and scientific in the way of why do we think that, or what do we observe and what do we expect? Because the persons, there are many persons in the artistic world that they do not respect physiology or science, and sometimes they say no, this is like that because it functions for me. It's like COVID, nah? It's because I had COVID and I don't have any symptoms. So that's why this is good to discuss that in a session about the muscle activity. That is what Ana Gloria is telling, and I think her work was wonderful about these wind players, because we cannot forget that they are instrumentalists and singers at the same times. And for example, the actors, they are also trying to make new techniques, and sometimes they are destroying. And we were talking about roof effects in the singing, and this is another approach, that we talk about roof effects on the singing voice. So we can discuss that. Just propose the topics. And I thank you very much. Ana Gloria was wonderful, and Ron, great as always. Soledad, thank you very much. Erki, thank you. And Catherine, thank you. We are beginning at 10 o'clock because of the time change in Mexico. Andrea Ricci Macarini, carissimo Andrea, I have written already to Franco, but I didn't understand and I was too busy. And Liza, as always, thank you very much. And please tell me which is your participation in the webinar of CoMeT.
The
That means,
webinar on which, the September?
yes, we
September.
changed. No, I told you before, let me see.
Yes, September 23rd.
No, this is the session. The webinar is going to be, webinar is 21st of October.
21st of
So yes, because
October.
you are on with your topic, and I would like very much if you send me your topic. It can be 15 minutes or longer if you wish, but
Okay.
don't forget it's for general population.
Yes.
That means that can be singers or actors, but they are not scientists, they are not speech pathologists, and they are not laryngologists
General.
or phoniatricians, the general population. That means our level of explanation has to be as easy as possible. So if you have some topic, please send it to me, because I am organizing the program.
Okay,
And
good.
I thank you, and Catherine and Ron and Andrea, of course you have to be there.
Also, I just wanted to make sure, because I researched about translation programs, and I just wanted to make sure you got my notice that after researching
Yes, I
it,
did, and I thank you very much.
we don't have anything really good yet. Maybe next year with AI it'll be better, but not yet.
But thank you. So we have to be together, and I wait for you 23rd. If you want to present something, please let me know. Anyway, we shall have a CoMeT member program as interesting as we had today. And I thank you dearly, all of you, Ana Gloria, Ron, thank you very much. And thank you to all of you for your time. Bye.
It was fun. Bye.
Kisses.
Ciao.
Bye. Thank you.
Bye.